This module focuses on internalized and interpersonal forms of discrimination and their impact on health. So this brings us to the other two levels of racism and discrimination articulated by Kamara Jones. Internalized racism, according to Jones, refers to subjective acceptance of a dominant group's attitudes towards subordinate race as inferior. And as Jones describes it, internalized racism can manifest in a number of different ways, including valuing whiteness, for example, in terms of appearance, physical appearance, skin color, etc. Devaluation of the self, including the use of racial slurs or the tolerance of racial slurs, and also simply internalized feelings of resignation and helplessness with respect to identification, membership of the subordinate group. Empirical research looking at the effects of internalized racism on health outcomes is fairly limited. However, much empirical research, mostly in the psychological domain and in experimental studies, that relates to internalized racism's concept of stereotype threat as articulated and studied by Claude Steele and colleagues. Stereotype threat refers to the threat of being viewed through the lens of a negative stereotype or the fear of doing something that would inadvertently confirm that stereotype. The threat operates more specifically when, for example, the quote, the event of a negative stereotype about a group to which one belongs becomes self-relevant, usually as a plausible interpretation for something one is doing, for an experience one is having, or for a situation one is in that has relevance to one's self-definition. It happens when one is, quote-unquote, in the field of the stereotype. This has been studied predominantly with respect to academic performance outcomes comparing blacks and whites, but also extended to look at a whole range of different groups who might be at risk for experiencing this threat of a stereotype and interpreting their own experience through that lens of a stereotype with negative impacts on their performance in a particularly relevant domain to that stereotype. What's important here is that an insight from stereotype threat is that while it's closely related to the idea of an internalized negative concept about a group, it doesn't have to operate when internalized racism, for example, exists, and when the notion of the stereotype or the negative perception associated with a particular group does not have to be internalized to the level of being accepted, but simply an awareness that the stereotype exists about the group to which you belong can put you at risk of this type of threat. And the effect of stereotype threat, or being in this field of the stereotype, as Steele and colleagues describe it, is that you experience an environmentally induced performance impairment. Again, without necessarily a pre-existing sense of group inferiority being part of that, but simply an awareness that the stereotype, women are not good at math, blacks do not perform well in academic endeavors related to IQ, etc. The existence of these stereotypes and awareness of them as being sort of out there is enough to induce this process described and studied by Claude Steele and colleagues. And what they observe is that the effect, they've demonstrated the workings of this effect through experimental studies manipulating a triggering of the stereotype. Some subjects are primed with mention of the stereotype when others are not. Those primed with some kind of trigger around that stereotype perform worse on a particular task to which that stereotype speaks compared to others who are not so primed. And the idea of the model here is that the overall effect of stereotype threat being around us all the time is a kind of hypervigilance, awareness of this threat and the stereotype, and the desire to not confirm that stereotype. And another type of effect over time, hypothesized to be relevant to stereotype threat, or as a function of it, is a kind of disidentification, a withdrawal from the threatening domain as a sort of self-protective psychological mechanism. Okay, I'm not going to invest in this domain because of internalized concerns about performance in that domain, and therefore if I disinvest, I won't care as much about it. And this is relevant because the evidence suggests that stereotype is particularly operative if there's an especially strong investment in the particular activity at hand. When there isn't a strong investment, then this identification problem does not activate the threat due to the stereotype to the same degree. And so you see this sort of negative cycle operating of disinvestment related to a domain where the stereotype may be operative. The model goes on to talk about remediation with respect to stereotype threat, modifying structural factors that might induce more stereotype threat, address things about attributional ambiguity, the potential, the greater potential for outcomes to be attributed to particular characteristics versus others by being really straightforward about what the particular domain is and taking active measures to counter the triggering of that stereotype. And in general, a kind of restoration of social trust is one of the remediations suggested by this work that might be important to try to overcome the negative consequences of stereotype threat. Again, this is mostly in the context of academic settings, undergraduate colleges, and so forth. And again, stereotype threat is not something studied extensively with respect to the impact on health and trying to explain racial differences in health, but its relevance for multiple pathways between racialized exposures and health outcomes is clear, including but not limited to differences in achievement academically and so forth. Okay, more broadly on the back to the Kamara-Jones typology, when we're looking at interpersonal racism and discrimination, we get to the type of racism that is most extensively studied when trying to understand racial disparities in health. And here we're looking at a lot of different characteristics, different domains of interpersonal racism, that which is experienced between individuals and is able to be perceived by the target or the receiver of that discriminatory racist encounter. And so in terms of domains, we're looking at things that might be day-to-day kinds of hassles or chronic stressors, in contrast to acute life events, which might be significant, more extreme, major events that don't happen on a day-to-day basis, but happen more episodically. So being fired from a job, failing to get a promotion, being arrested for something that is clearly in the context of bias operating, although for many, encounters with the police, racialized encounters with the police is an important domain related to daily hassles, unfortunately. And so this distinction, again, between kind of chronic daily occurrences and acute episodic life events maps closely onto the distinctions we make more broadly about the type of stressors people encounter in their lives. Important dimensions that often need to be captured to try to understand the totality of how racism is experienced in this way and how it might be relevant for health outcomes include just simply the exposure itself and the degree to which the frequency of occurrences of interpersonal discrimination. Also, the question of how individuals who experience these events make sense of them and to what they attribute that type of interpersonal encounter or unfair treatment. So the extent to which it is attributed to, it is praised as being unfair or bias is operating, and then beyond that, the extent to which the perceived bias involved is attributed to something like racism as opposed to sexism, classism, bias related to religion, etc. Another important dimension of interpersonal racism relates to how individuals respond to or cope with those experiences, whether or not their responses are more internalized, they're not talking to anybody about it, keeping it to themselves, etc., or externalized in some way, which might include behaviors ranging from simply talking to a confidant, a friend, all the way up to reporting an experience to a supervisor or some other kind of authority figure who might be in a position to take action against the person who's perpetrating this racist event. And also in terms of measurement, we are looking at a number of different types of measures, most of which rely on self-reported perceived discrimination. Others have used measures that don't rely on self-reported experiences, but instead use things like phenotypic characteristics like skin color. Some that are ranging in subjectivity to objectivity, whether they're using metrics that actually categorize skin tone along a spectrum, or more observer-assessed categorizations of people's race or skin color as a way of capturing phenotypic distinctions that correspond to race and might be implicated in individuals' exposures to racism. The self-reported measure is much more prevalent, and also here the use of the word perceived is very relevant, because with self-reported measures of interpersonal discrimination, it's impossible to distinguish between what actually happens and what people perceive has happened, something we'll come back to later. So again, this is the domain of discrimination where most of the research is happening. And in the form of population-based studies, most of that research is based on subjective perceptions of experiences of racism or discrimination and self-report of those experiences. Another form or type of research study which has generated a lot of this is experimental psych studies, which manipulate exposures and can document the extent to which individuals enact racist events and also perceive racist events, and how those events might be correlated to short-term health outcomes or health-related outcomes like psychological distress. In those cases, we're assuming a stress pathway here. Obviously, an instance of interpersonal discrimination or personally mediated discrimination such that somebody who's in a position of hiring does not hire somebody because of this color of their skin, obviously that has important structural implications for that person's outcomes. That means less access to the job and the resources that go with it. But what we're talking about in the research domain here is more about how individuals experience and are aware of actual events, exposures of discrimination, and how that awareness of that exposure affects their health. So not getting hired because of a racist employer has implications for health through resource pathways. But here what we're really focusing on is the ways in which people's perceptions of experiences of racism might be directly relevant for their health outcomes through more stress pathways. And those stress pathways can be direct through cardiovascular reactivity, or they can be more indirect, operating through health behaviors like smoking as a way of coping with the exposure to that stressor. Overall, the research suggests strongest outcomes for associations for mental health outcomes in the domain of mental health. Although again, studies looking at outcomes related to blood pressure and other types of cardiovascular outcomes also show results, although not always in the direction expected. With respect to perceived discrimination, we observe some pretty consistent population-level patterns in the reporting of the exposure. Not surprisingly, higher reports of discrimination experienced among non-whites relative to whites. On balance, less intuitively perhaps, reports of discrimination are positively associated with socioeconomic position, higher among men than women, with in particular gender differences in the types of situations where interpersonal discrimination is encountered. So for example, men are much more likely to experience interpersonal discrimination at the hands of police officers than women. Prevalence, however, in studies of reported discrimination varies, but often as high as 80% among blacks in the U.S. Again, we see stronger, more consistent negative implications of perceived discrimination for mental health outcomes. Less so, a little bit more ambiguous with physical health outcomes, where the association is not observed in 63% of studies in this one review published in 2006. With health behaviors, we find that in 62% of the studies included here, there was a positive association between perceived discrimination and health behaviors. These are bad health behaviors that are not good for you. But really the strongest association here is with negative mental health outcomes. One slight exception to the pattern of results with respect to physical health outcomes is perinatal outcomes. And here you see that there's a really strong correlation between, or consistent finding between perceived discrimination and negative perinatal outcomes. Although, again, many studies showing that there are no association between perceived discrimination and perinatal outcomes. Another form of racism not included in Kamara-Jones typology, and also not extensively studied empirically with respect to effects on health outcomes, but still relevant and worthwhile mentioning, is this concept of aversive racism, introduced by Davidio and colleagues many, many years ago and studied extensively as a way of capturing what is often referred to as modern racism or symbolic racism, in contrast to the traditional old-fashioned overt racism. This is more implicit bias, more subtle forms of prejudice that we think of as being sort of the way prejudice operates now in a contemporary way. So it's expressed less directly and overtly, more indirectly, often unintentionally. However, relevant because the consequences for the enactment of these prejudices, for example, through restriction of economic opportunity, may be as significant and as pernicious as those of the traditional overt forms of prejudice. One of the reasons why aversive racism is considered to be more emblematic of modern, contemporary types of racism is because aversive racists will simultaneously possess strong egalitarian values that they espouse and believe they themselves are non-prejudiced, but at the same time will harbor negative racial feelings and beliefs of which they may not be aware, or at the very least are not willing to acknowledge because of sort of socialization to be egalitarian and so forth. And these contradictory values and feelings are the sort of terrain where aversive racism plays out. And because they do not consciously endorse racism, to the contrary, they will not overtly discriminate intentionally, but due to the negative feelings, prejudices they harbor, they will discriminate, often unintentionally. And especially when the behavior in a given task can be justified on the basis of some factor other than race. So again, this is in the context of social psychological studies. One example back in the 70s of the workings of aversive racism comes from an experiment where half of the participants were led to believe that they were the only witness to some kind of contrived emergency. The other half were led to believe that there were other people who were also witnesses to the emergency. And what varied in this experiment was the race of the putative victim. In half the cases, the victim was white, and the other half, the victim was black. And what they speculated was that whites would not discriminate against the black victim when they were the only witness, because then how could they justify this? It would be hard to justify it as something other than racism or due to racial bias. However, because they have these unconscious negative feelings, the hypothesis was that whites would discriminate against the black victim, meaning not intervene to help, when they could justify their behavior based on some factor other than race. In this case, the belief that somebody else, one of the other witnesses, would help the victim. And when this experiment was played out, they found that indeed when whites were believing they were the only witness to an emergency and the victim was black, the intervention to help the victim for blacks was comparable to that when the victim was whites. However, when whites believed that there were two other bystanders available to help this victim, they helped the black victim half as often as they helped the white victim or Confederate in this particular study. And so here, when there is a variable that can be invoked consciously and subconsciously to justify not intervening in something, that is sort of cover for the subconscious operating of these internalized negative racial feelings. Here we'll talk a little bit more specifically about some of the measurement choices and options that are used in the field to understand the effects, in this case, of interpersonal or personally mediated discrimination in health. Again, there are several different domains that are relevant to the measurement of perceived discrimination. One is the frequency and severity of events. How often did this happen, and how upsetting was it to you? How much did this bother you, for example? There also may be attention to the behavioral or cognitive response style. Again, the extent to which people respond by externalizing or internalizing their reactions to these events. The number of domains is another important dimension, and again, really important when trying to make sure that there is a valid measure for a particular subgroup experiencing discrimination. Some individuals may not experience discrimination in certain domains and others might experience them at a much higher rate. So again, being followed in the store, being tracked on the street, having people act like they're afraid of you is a much more prevalent form of racial experience that pertains to men relative to women, and other subgroup differences might really matter when trying to capture the types of domains where these events might occur. Again, this distinction between things that are acute and maybe more episodic versus chronic and ongoing, and the recency versus the life history of exposure is another distinction that's often relevant for measures being used. Also, the approach to attribution in different measures, as we'll see in a moment with some examples, may vary with implications for the extent to which the perception of unfair treatment is independent from or conflated with the attribution for that unfair treatment. And ultimately, the research question needs to guide the choices used with respect to these different domains. Here is one example of the schedule of racist events. This is a little bit of an older measure. Here, the attribution and the perception of bias and the attribution is implicit in the initial STEM question for the domains of exposure. How many times have you been treated unfairly by teachers or professors because you are black? So here, the attribution to racial bias is implicit, it's explicit, and it is inextricably linked to the question at hand. They're asked about the temporality, the recency versus entire life, as well as the severity, all as part of this measure. And then the domains include things like academic contexts, employment, job situations, people in service jobs, people who are performing service jobs, strangers, neighbors, and so forth. In addition, the schedule of racist events also asks more questions that are a little bit more global in nature. How many times have people misunderstood your intentions and motives because you are black? The attribution, again, is included in the question STEM. How many times did you want to tell someone off for being a racist but didn't say anything? How many times have you been called a racist name, etc.? The Williams et al. Measure, introduced in 1997, is one of the more popular and pervasive measures of discrimination used, and it makes this distinction explicit between major and everyday discrimination. The major events are the sort of acute, episodic things that might have happened ever in one's life. Do you think you've ever been unfairly fired for unfair reasons? Do you think you have ever not been hired? Do you think you have ever been unfairly stopped, searched, questioned, physically threatened, or abused by the police? Again, I think this last question reflects maybe a time before one appreciated the extent to which policing tactics like stop and frisk became so pervasive that these were not major episodic events but daily occurrences, to be stopped and searched and questioned by the police simply because of your appearance or who you were congregating with on the street, not because you were engaged in any explicitly suspicious activity. And here you can see that while the appraisal of bias is included here by asking questions about unfair treatment, the attribution is not. And that's true for the everyday chronic discrimination experiences component as well. Asking about how often you've been treated with less courtesy than others, less respect, receiving poor service, people acting as if they're better than you, they're afraid of you, etc., being called names or insulted, threatened, or harassed. The way this measure works is by keeping separate the attribution. Respondents are asked to respond to these occurrences, whether or not they've ever happened, and then asked separately to refer back to items they endorsed as having occurred to them ever or in the past year, and then attributing those occurrences to a whole list of possible reasons: race, age, weight, gender, religion, ethnicity or immigration status, etc. And so the attribution component of the question comes separately. It also allows for people to attribute this discriminatory treatment to multiple factors or to different factors rather than simply just to racism. One important feature of all of these measures is that even if they also ask direct questions about your perception of having experienced discrimination or racial bias and so forth, They're behaviorally oriented. They're asking very specific questions about these events. And the reason why this is really important is because with all measures of this nature, it's important to be able to distinguish at least somewhat between what people have experienced and are able to identify and recall and willing to report, and how they interpret that event. So for example, when we ask people about whether or not they've ever experienced domestic violence, we don't ask them, have you ever experienced domestic violence? We ask them, have you ever been hit? Have you ever been struck with an object? Have you ever been insulted or threatened? You're asking about specific behaviors or instances of occurrence without asking them to name it as domestic violence. And here you can see that while there are included in these measures items that ask about individuals' perceptions of being discriminated against and named as such, or being on the receiving end of racial bias, you're also trying to ask simply, I think the Williams measure most clearly, about just whether you've experienced these things, period, separately from how much you interpret these events to be about bias on the behalf of the perpetrator. The Krieger measure, experiences of discrimination, also gets at a lot of these different domains, and the attribution here is about only race, ethnicity, or color, so it's really getting at racial ethnic discrimination, and it's included in the question stem. So here, as well as the term discrimination. Whether you've experienced discrimination, been kept from doing something, hassled or made to feel inferior, in all of these different domains and with their frequency. So here, you're not really able to separate out the event from the person's attribution to racial bias. And, that to some extent that's inevitable, because if you ask somebody simply, have you ever not received medical care, you're not able to even begin to approximate something that is attributable to racial bias, given the whole host of reasons that might be operating why someone didn't get medical care, including because the clinic was closed. And so I think that these measures highlight the complexity of trying to capture an event that is an experience, an exposure that is really hard to disentangle from subjective meaning, the perception versus the reality piece. And that's not necessarily a bad thing, though, something we'll come back to. Krieger also includes explicit questions about how your motive style in general in reacting to unfair treatment. If you feel you've been untreated fairly, do you usually accept it or try to do something? Do you usually talk to others or keep it to yourself? So again, this is the response mode or coping style. She also includes some generic or global type worry questions. When you were a child or teenager, how much did you worry about people in your group experiencing unfair treatment? And when you were a child or teenager, how much did you worry about you experiencing unfair treatment? And this is trying to get at, again, another dimension of this, which is the sort of the mental preoccupation and concern about experiencing racial discrimination, but it's also trying to capture something that has been observed, which is the fact that people are often much more willing to, or readily able to acknowledge the fact that the group to which they belong is at risk of or experiences discrimination than they are to acknowledge that they themselves have been the recipients of discrimination on that particular group attribute. So black people might be more willing to say, yes, black people in the U.S. experience discrimination all the time. I myself have not experienced discrimination, but my group, the group to which I belong, is definitely at risk for experiencing high levels of discrimination. And this bias has been documented psychologically, and this is also an attempt to try to get around a little bit by asking about the degree to which one perceives that the group to which they belong is at risk of discrimination. And finally, some global questions about the perceptions of racial and ethnic discrimination in terms of in all respects. And this is something that can be looked at in comparison to the item-specific forms of discrimination that are captured in the other parts of the measure. Now, again, this question of the inseparability of the event that happened and how one subjectively interprets it it's not necessarily a problem. It has strengths and limitations either way. The fact that these experiences are subjectively assessed and ascertained matters because in this case, the hypothesized mechanism is a stress response. So if you don't see it, you may not be necessarily experiencing it, even if it happened. And so here, subjectivity is actually very relevant because you want to capture the extent to which somebody is experiencing the stressor, aware of it, and therefore at risk of a stress response. The self-appraisal limitations might be related to the fact that you again can't make this distinction, and somebody might be more or less likely to interpret a given experience as having to do with bias or not. And here this is things like personality variables, paranoia, negative affect, and so forth that might predispose one person versus another to have a particular interpretation that might confound the results when you're trying to understand the effects on health outcomes. Now, the flip side of this is that objectivity matters, perhaps because often even discriminatory experiences that are not noticed may have insidious effects. So having objective awareness of, knowledge of events that occur to individuals might be very relevant, and doing so would avoid the confounding we just discussed. The limitations are, of course, that it doesn't capture the effects of perception if you are able to capture objective, independent experiences of discrimination. Ilan Meyer, in this 2003 piece, further elaborates on the pros and cons of subjective measures, including the fact that the elicitation of subjective measures may be important in terms of empowering the perspective of the members of the groups that are experiencing discrimination. And the downside, the flip side of that, is that measures that that are eliciting subjective accounts of discrimination might implicitly be interpreted to blame the victim if the person reporting discrimination is discounted, and that those experiences are discounted as being sort of all in their head or all about their perception as distinct from the reality. And also, Meyer points out that the wording of questions can be really highly influential in the ways in which people are willing to report experiences of discrimination, and most importantly, how they interpret discriminatory experiences. It's very hard to ask those questions without having a moment of intervention in and of itself that has the effect of triggering processes of interpretation that might not have existed or that might now exist in one direction versus another. And so the influence there on question wording may also affect the results captured. And of course, if we're talking about subjective measures, we are talking about what can be seen and what is personally mediated. And we're missing a lot of institutional or structural forms of discrimination that are not evident to the respondent on the survey. And so if we overly rely on the interpersonal mediated discrimination, we're not capturing important forms of structural discrimination that can be, of course, hugely important for health outcomes. Further advantages and disadvantages of the objective measures versus the subjective. So with objective measures of discrimination, again, the confounding is less of an issue. If there are instances of discrimination documented that are actually related to legal rights and limitations, these are points of intervention that can be targeted, like the audit studies suggest, that this is operating at the level of structural mechanisms that could be the focus of interventions to reduce discrimination. Another important limitation of objective measures or measures of structural discrimination is the extent to which, though, we might be dealing in the realm of ubiquitous exposures. If discrimination is widely practiced, legally sanctioned, and so forth, we can't isolate the effects of that discriminatory practice because there's not enough variability in order to be able to study its effect. And of course, many forms of discrimination remain concealed, disguised, the types of insidious, aversive racism, symbolic modern racism are not things that are able to be captured in the discrimination measures we're able to use. And finally, we have a number of hypothesized effect modifiers that are believed to and are studied with respect to how they might modify or mitigate the negative consequences of exposure to racial discrimination and health outcomes. Racial ethnic identity is an important one, the extent to which a positive racial identity and ethnic group membership might mitigate the effects of discrimination. Also, psychological dispositions themselves can be productive, but are usually more thought of as an individual level phenomenon rather than a group level phenomenon. Socioeconomic position has often been hypothesized to be an effect modifier of the relationship between discrimination and health. However, the direction of that effect modification can go either way. That socioeconomic position, higher SES, could mitigate the effects of discrimination if, for example, people have more resources to offset or compensate for the discrimination and do something about it, or have resources that enable them to cope with it better. The socioeconomic position may also, higher SES may also exacerbate the effects of discrimination on health because of expectations that with higher education, occupational status, and income, one should no longer be exposed to these kinds of discriminatory events. So how is the insult, psychological insult of being pulled over or harassed by the police on the street because of the color of your skin different whether you're high SES or low SES? It's an open question, but one can hypothesize that the effects could go in either direction. Coping responses, again, are hypothesized as a really important modifier of the effect, whether it's internalized or externalized, and then the effect being relevant to the access to social support to help one process the experience, validate the experience, help make sense of it, help access resources to cope with it, and so forth. And in general, the social context itself is understood as an important potential effect modifier. More broadly, the extent to which one is in an environment that is sharing an experience versus one that is more isolated. A social context where there is explicit statements, policies, environmental cues that racial discrimination is not acceptable will be a social context in which individuals who experience instances of discrimination will feel more likely to feel empowered to do something about it or feel validated in the negative response that they experience to that discrimination and find more recourse for social support, etc.